Good afternoon, ladies and gentlemen. We will call to order the House Insurance Subcommittee for Tuesday, April 6th, year 2021. Shelley, on the microphone, would you please call the roll?
Representative Subcommittee. Representative Hicks. Representative Kumar.
Here.
Representative Lafferty. Here. Representative Mitchell.
Here.
Representative Rudder. Representative Smith. Here. Representative Terry.
Here.
Representative Thompson. Chairman Hawk.
I am here.
You have a quorum.
Thank you. Chairman detects a quorum. Does anyone have any personal orders that they'd like to state before we begin? Seeing none, we do have a calendar before us, and I will make some announcements on a few pieces of legislation as we go forward. Item number 1 on our calendar today is House Bill 988. Chairman Williams has asked that we take that bill off notice. Without objection, House Bill 988 is taken off notice. I have just received a communication on item number 3 on our calendars from Representative Potts, House Bill number 1453. We were going to roll for 1 week. Once again, House Bill 1453, roll 1 week without objection. And I think that may be all of our preview work to work on. All right, I believe it is. We do have a calendar before us, and we have item number 2, as we've disposed of item number 1 off notice. Item number 2 on our calendar is House Bill 736 by Representative Miller. Motion. Representative Miller, we have a motion. Sir, I do not detect a second. Excuse me, we do have a second. You are recognized, Chairman Miller, on House Bill 736.
Thank you for the second. Thank you for the motion. Mr. Chairman, House Bill 736 would repeal Title 71, Chapter 5, Part 126. Simple bill. The bill authorized the governor to negotiate Medicaid expansion without the approval of the General Assembly. This bill does not require Medicaid expansion, but it does empower the governor to explore the opportunity. Here's why it's important that we do this now. The American Rescue Plan that was recently approved by Congress and signed into law creates an incredible opportunity for states that have not expanded Medicaid. Now, you all know there's a federal state match 9-to-1 with Medicaid expansion, but under the American Rescue Plan, TennCare would receive about $1.3 billion if the governor chooses to expand. That's enough money to completely pay for an expansion program, free and clear of state dollars for 7 years. Not only would we get insurance to working families, these funds could also be used to boost provider rates, which are a major problem, or we could even enhance coverage options. Here's the catch: the clock is ticking. The offer included in the American Rescue Plan doesn't last forever. If we wait, we could miss out on some of these dollars. That's why the bill is needed right now. When the General Assembly closes, we should leave here knowing the governor can take action to pull these dollars. It's a limited amount of time, and we could cover between 200,000 and 300,000 Tennesseans who cannot afford private insurance. As some of you may remember, the last time there was a special session called by then Governor Haslam, negotiated with the Department of Human Service for at least 2 years, came back to the General Assembly. They would not even allow the bill to be heard in the House. but it was heard and debated in the Senate. The bill failed by 2 votes. In the process of that, the state of Tennessee has foregone potentially several $1 billion in lost revenue. Let me say this, Mr. Chairman and committee members, about this bill. Number one, the bill hadn't been flagged by the governor. And of course, you know, anytime, even your bills, if it's something that the governor cannot support, doesn't support. So I assume that the governor may very well be neutral, unless you've heard or know something different. Right now, there's a discussion in the Senate with Lieutenant Governor McNally and other members. Matter of fact, I was planning on rolling this bill, but I heard this is the last meeting. The bill will be heard in the Senate tomorrow, and I wanted to give Senator Yarbrough, the lieutenant governors, and others the opportunity to at least begin to have the conversation, just a crack in the conversation, as we say. My plans, Mr. Chairman, was simply to try and park the bill full committee, let them continue that conversation. And another thing, knowing that the block grantors are focused, the federal government is looking into it, attempting to make a decision, but we can do both. You can do the block grant as well as consider expansion. It makes sense if we could ever put aside the politics of expansion. Open for any questions, Mr. Chairman, if there are any.
Thank you, Representative Miller. Any questions or comments for the sponsor of the legislation? Representative Mitchell, you're recognized.
And I'll be quick, since I appreciate my colleagues, you know, hearing the sponsor of the bill out. You know, we can't continue down this path. We can't continue making an $8 billion mistake in this state. You know, I don't know where we are on calendar, Mr. Chairman, but, you know, for some unknown, unforetold reason, the Senate does do something with us tomorrow. I'd hate to know we missed out on the opportunity. I don't know if we're meeting again next week, but if we could just, you know, roll this for a week. Are we meeting again next week?
Make 2 clarifications as you asked the question, and I'll clarify for the sponsor of the legislation as well. We have announced our last calendar will be next week, so we do have a last calendar for next week. Additionally, the legislation has received a flag from the governor. I'm not sure how recent the flag in opposition to the legislation, but it has been noted that there is a flag of opposition from the governor on this particular piece of legislation as well. So 2 corrections as we go forward. Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. Since I hint a cold wind blowing in here, but I would say, you know, part of the judgment of the chair, if we could, and the sponsor agreeing to, if we could just roll this to next week, and for some reason that it does go forward in the Senate, hear from him again, but if it dies in the Senate, the sponsor will agree that he'll take it off notice. If that's okay with you, Mr. Chairman. If just in case it does do something, then I'd hate to miss that opportunity. $8 billion is $8 billion.
Understand, and as we've most recently worked on what Chairman Terry reminds me of our shared savings plan and what we're looking at and the opportunities we're looking at there. So, and Chairman Terry has a piece of legislation that he's also addressing later on this calendar as well that has some similar aspects to it. Sorry. Chairman Subcommittee, you're recognized. Question has been called. Chairman Miller, Representative Miller? Okay.
no big deal.
I will allow a roll call vote. Chairman Miller, you are recognized for closing comments.
Thank you, Mr. Chair. But again, it's a simple equation. I just simply wanted to roll the bill because you did correct and say there is one more meeting. The intent is to see if there's any communication in the Senate. No gain, no loss. I mean, what is it that we're avoiding?
Understand?
It's a simple. There's billions of dollars that are. The federal government has changed their rules in order to be more acceptable to those states, including Tennessee, that are, for whatever reason, has been resisting for over 10 years Medicaid expansion. I don't understand the resentment almost of wanting to at least have a conversation.
We're voting on the bill. Shelley, call the roll. Please call me first.
Chairman Hawk?
No.
Representative Sapicki? No. Hicks?
No.
Kumar?
No.
Lafferty?
No.
Mitchell?
Aye.
Rudder?
No.
Smith?
No.
Terry?
No.
Thompson?
Yes.
You have 2 noes, Chairman, and, I'm sorry, 2 ayes and 8 noes.
8 noes, 2 yes. The bill fails. Thank you. We're now on item, after rolling House item number 3, we're on item number 4 on our calendar. Chairman Terry, you recognize item number 4, House Bill 875. Have a motion and a second on the legislation. Chairman Terry, you're recognized.
Thank you, Chairman and Committee. And I ran a bill last year, and this is similar to the last bill that we heard in that I am looking for a way for us to have a discussion on the uninsured. And it's, with the estimated number of Tennesseans that have no insurance, approximately 1 in 10 of the state, and those are healthy and are uninsured. Most of those are healthy, uninsured and unable to afford private insurance. With increasing health insurance rates, healthier individuals tend to opt out of the market. When they leave the pool of insured, the risk for those that remain increases, which in turns causes insurance rates to increase more. The question that I pose is, with a significant number of uninsured Tennesseans, is there a way for us to increase insurance access without expanding Medicaid? Can we offer an affordable commercial health insurance plan to these uninsured individuals utilizing a private sector driven alternative to TennCare or to Medicaid expansion? I had a health issue last week, and so I was not able to attend the meeting, but we did go out of session and heard from an individual that spoke to that. This is a conversation that I do think we need to have, is what can we do from a private sector standpoint to help those uninsured? I'm at the will of the committee on this, whether it's to have a actual summer study on this. Last year when I ran the bill, DCI is, my understanding, is pretty run pretty lean, and it had like a $90,000 fiscal note on that, and so it was derailed by COVID, but it would have gone behind the budget. But I do think that's a discussion that we need to have as far as what we can do. So I'm at the will of the committee. I'm willing to have this go to summer study. I'm willing to have this parked in full. I'm willing to take it off notice. It's whatever the committee would like for us as far as discussion we need to have.
Thank you, Chairman Terry. Chairman Kumar, you're recognized.
Thank you. I really admire Chairman Terry for addressing a problem of so many people who are uninsured and what to do about it, sincerely. I'd be happy to join you if you choose to do a study. It's a balance. How do we decide what people need? Do they need a catastrophic insurance that will cover them for expenses that are much larger, yet few people will need that insurance? Or do we need an insurance that caps the benefit, is equally inexpensive but caps the benefits at, let's say, 20, 30,000 or so, which is the insurance that they are more likely to use for common illnesses that happen more commonly. And I think it'll be great for us to be able to discuss those matters. And I thank you for bringing this. I think this is good. We are really finally addressing the situation. I'd be happy to join you, and thank you, Mr. Chairman.
Thank you, Chairman Terry.
I just thank you for the comments. And I mean, if we are truly going to study this, if that's a motion for this committee, I mean, I think it's something that we do need to discuss, and we do need to study and see how we can get private insurance affordable to these individuals.
Okay. I'm going to go to Representative Thompson in just a moment, sir. I'll come to you in just a moment, then Representative Mitchell. Do want to ask of Chairman Terry, would you like us to adopt the amendment to have that a working document if we do intend to send the bill to summer study?
That would be at the, yes.
Okay. Thank you. We have a motion and a second. Amendment code, ladies and gentlemen, is tracking code 5866. Once again, the amendment code tracking 5866 is in your packet. All those in favor of placing amendment number 1 on the bill, number 875, please signify by saying aye.
Aye.
Any of those opposed, please say no. The ayes have it. The amendment is adopted. We will go to Representative Thompson now.
Okay, as I understand, thank you, Mr. Chairman. As I understand it, this is a weaker plan that was previously proposed that's going to be more expensive to the state, which personally I see no logical sense. This is, as I understand from the Chairman Terry's description, it's a totally private insurance plan in comparison with a public-private collaboration plan. Now, I'm not going. Again, I'm just as confused as anyone about why we rejected the previous bill, but I'm certainly not going to say no to any plan that will potentially cover the Tennesseans. So I'd be agreeable to a summer study. The only thing I would ask is that the summer study also include a head-to-head comparison between this plan, the Affordable Care Act, and any other plan that might come up besides this one. Thank you.
Thank you, Representative Thompson. I'll remind you, we're talking about this legislation. The prior legislation failed. So we were talking about this legislation. Representative Mitchell, you're recognized.
Yeah, like my colleague, I'm going to be consistent. I'm going to support this legislation. I don't know if a summer study is the best thing, but anything that says Title 71 and keeps the possibility of covering 300,000 Tennesseans alive in this state, I'm for it. I'm just asking if we're going to go to a summer study, let's go to a summer study and hang our D and our R at the door and worry about dollars and cents and worrying about the 300,000 Tennesseans that don't have health care. I don't care if the previous Democratic sponsor of the legislation walks up there and we pass it, or my Republican colleague next to me passes it. I don't care who passes it. As long as we get health care for 300,000 Tennesseans, I'm for it. So I'm for his legislation. I say we keep it alive until our last meeting. Thank you.
Motion before us is for a summer study on House Bill 875 as amended. Hear a second? Do you hear a second? All those in favor of sending House Bill 875 to summer study, please signify by saying aye. Any of those opposed, please say no. The ayes have it. Your bill is sent to summer study, sir. All right, we are now on item number 5 on our calendars. Item number 5 is House Bill 1258, 1258. Representative Smith, you are recognized.
Thank you, Mr. Chairman. And I do have an amendment to add to this. It's drafting code 6197.
Okay. I think your amendment has already been adopted in tracking code 6197 has already been adopted. We are searching a motion in a second. Okay, we have a motion and a second on the legislation. You are welcome to entertain explanation of the legislation as now adopted. Chair Lady Smith.
Thank you, Mr. Chairman and committee. The Health Services Development Agency has brought this bill to me requesting enabling legislation to pursue a $2.5 million grant that was created through federal legislation back in December 2020 in the United States Code that addresses surprise billing. Within that federal legislation, expenditures were made available for states that do not have an all-payer claims database. All-payer claim databases are employed currently in 23 states. Tennessee does not have such a database, and the purpose of a database for that would be to use geographic mapping of chronic diseases. I know that in our previous committee in health, we heard some testimony and references to the Commission on Aging and Disability task forces, such as the Opioid Task Force, the tracking of information about Alzheimer's. All of these things are important to Tennesseans and our health, but we do not have a tracking mechanism to study not just the claims that are submitted for the treatment of these ailments, but also the effectiveness, the cost, as well as the outcome and the value. This would permit the HSDA to pursue a $2.5 million grant to set such an entity up, and this would collect information which would include, but not be limited to, pharmacy benefit information, workers' compensation information, health care plans, as well as some of the more demographic information that's affiliated with ailments. And with that, Mr. Chairman, I'll be happy to take questions and offer comments on the bill.
Thank you. Questions or comments? Chairman Sapicki and then Chairman Kumar after that.
Thank you, Mr. Chairman. Chair Lady Smith, one of the concerns I have on this bill is data security. Mm-hmm. Can you talk about the data security? Because there's going to be a third party handling all this. Is this correct? And then address the data security to make sure that we're taking all the necessary precautions to make sure that this doesn't have a breach.
Forgive me, Chair Lady Smith, you're recognized.
Yeah, Mr. Chairman, and to my colleague's question, I do have that information. I know that Logan Grant is here, who's the Executive Director of HSDA, and I think that if it would be appropriate for us to go out of session and allow him to offer a thorough explanation since they are bringing this bill.
I do have Logan Grant on the list. Chairman Kumar, did you want to ask your question before we go into recess? No, I don't. Okay. Logan Grant, Mr. Grant, if you could please come before us. I'm glad you're here. We do have several questions. I have some questions myself. Without objection, we will go into recess. We are in recess. Mr. Grant, if you could please introduce yourself, tell us who you are and who you're with.
Good afternoon, everyone. My name is Logan Grant. I'm the Executive Director of the Health Services and Development Agency.
And I'll recognize Chairman Sapicki to either restate your question or if you're ready to go, Mr. Grant.
If you understand the question, I'll wait your answer.
Yes, sir. Sorry. 23 other states have already established all payers claims databases, and in that, the vendor contracts go through very detailed protocols for how to protect patient data. And to my knowledge, there have been no breaches so far. They adhere to the same standards that the insurers do in transferring data. The way that they do it, most commonly, is they will create a special encryption key for each submitter of the data. The data will then be encrypted in that special form, and then once it's submitted, it will be stored under a different encryption, and then only a few designated people are able to even access the database. At our agency, it would be limited to maybe 2 or 3 people who can even access the database. All their movement, all of the research that they do in that database would be tracked and logged. So there would be, I think there's very adequate protection of patient data.
Chairman Sapicki, follow up.
So just for clarification, I'm working for your department and I'm one of those key access people, and I decide to leave your department. What happens next? Because I have the ability to gain access because of whatever codes or combinations you have set forth. How do you address that issue?
Well, I think similar to turning in your office keys, you would probably your login information would no longer function.
Perfect. Thank you.
Thank you. Chairman Kumar, you're recognized.
Thank you, Mr. Chair. Just to clarify, my understanding is that an all-payer claims database does exist at this time. It's not been very functional because of lack of proper reporting.
So that is correct. The state of Tennessee established an all-payers claims database in 2009. That was under the Breslin administration at the time. And what happened was it was still kind of a novel concept. There were only a few states that had them at that time. And when administrations shifted, I don't know that there was necessarily any buy-in as to how to implement it. And I would say that when they ran into difficulties in implementation, they had trouble. I know that they had trouble with the vendors. I don't know that those challenges were really overcome. APCs have really come a tremendously long way since then. There's several vendors that I've spoken to that provide those services in multiple states, and collecting data is not an issue. I don't anticipate would be the issue it was back then.
Chairman Kumar.
Thank you. Just full disclosure, it's not that I'm smart. I had that information. I was told by the department. So it was not functioning well, I understand, because of poor reporting and not enough enforcement. Do you think, I would hope, that now what we established will be better functioning and we've taken steps to ensure that?
Yes, sir, I believe so.
Thank you. Thank you, Mr. Chairman.
Thank you. Representative Mitchell, you're recognized.
Thank you. So 29 states are doing this. How many different vendors are there in those 29 states?
In the 23 states, I can't recite how many there are exactly. I know that there are, there's 3 that we spoke to that each do it in probably at least 2 or 3 states.
Okay. So I'm foreseeing a similar database similar to what CMS has, correct?
I'm not familiar with what database you're referring to. Are you talking, could you explain?
Center for Medicare Services, I mean, they put out data on the cost and the number of different procedures for everything Medicare does.
Correct. That they have Medicaid-specific data, and we would.
Right.
This would also go through a process by which we can obtain Medicare data from them.
Okay. So similar to what already exists.
Yes, sir. Except we would be pulling claims data from several different payers. So we would be getting at populations we otherwise couldn't obtain information about.
All right. Thank you.
Representative Smith, you're recognized.
All right, thank you, Mr. Chairman. And I think one of the questions that was prompted by Chairman Subcommittee that I want to make sure that you read into the testimony is that this will be housed in the Health Services Development Agency, and it will be used only within the confines of the state. This will not be a public, no one can go onto a portal and access this information, but even within the state to look at it, let's say that the Commission on Aging wants to look at this, there would have to be a memorandum of understanding engaged with the Department of Health, and then that information will be de-identified for the purpose of utilization. If you could speak kind of to that process, because I want people to understand that this is not something that's going to be a public price list. It can be used to analyze cost and value, but this issue of having a very robust protection about information is important to all of us, but we also know that this is a valuable tool. And then secondly, if you wouldn't mind, as I understand at the federal level, there is a construct of the database that's being put forward like a template, that there are minimum standards that have to be met. If you could speak to those. Thank you, Mr. Chairman.
Absolutely. So to your first question about the protections for access to the database, it will not be accessible by the public. The database will actually be governed by a Health Information Committee. The Health Information Committee is going to have include some state officials, some healthcare providers, and representatives of the insurance industry, and some consumer representatives appointed by the House and Senate speakers as well as the governor. And I think additionally, there's also going to be 2 legislative non-voting members in order to maintain legislative oversight. I'm very proud of this model as something that would really provide a lot of opportunity for collaboration and oversight by the General Assembly. I think that the committee will have to approve all memorandums of understanding with other departments, And we are, on this legislation, we're still working on, we are still open to language that would tighten it up further. I believe we've had some discussions about that just to put further guardrails. I believe that the amendment in front of you does have adequate protections in place, but there's more that could be stipulated that we're working on.
Okay, Chairman Kumar, do you want to be recognized?
Yes, thank you, Mr. Chairman. Thank you again. Overall, it seems like a useful thing if we have data that is good, available, and well managed, that can be useful for pandemics. And well, I would rather ask you, what will that data be used for, and who will it be available to?
Thank you. That's a great question. Some of the areas that I'm particularly interested in looking into are tracking the utilization of telemedicine, trying to evaluate where that is being adopted very commonly, where is it successful, especially in rural areas. Is it really increasing access? Is it lowering costs? Is the quality improving? There's a whole lot of things like that we could do. Additionally, tracking the prevalence of chronic diseases. If there's a particular chronic disease in a certain area of the state, we could identify that and begin asking questions. Why is that the case? Why is that the way it is? Additionally, hopefully, I think this could be very useful to the Department of Health because they fund a lot of different types of interventions, public health interventions. This could help them target some of those taxpayer resources to be even more efficient.
Well, thank you. It seems that it is information that will be useful to the state and in the realm of public health. And I think you will manage it well. Thank you. Thank you, Mr. Chairman.
Thank you, Chairman. I'm going to go back to Chairman Subcommittee, and then I'm going to go to Chairman Terry after that, and then the Chairman has a couple of questions after that. So Chairman Subcommittee, you're recognized.
Thank you very much, Chairman. So I want to get you on the record on this. So will the federal government have any access to this information either in the capacity of normal operations or in the event of a pandemic or a national state of emergency? Would they have access into this information?
They would not have access to this information and I would think that it would be very constitutionally dubious for them to try and obtain it during a pandemic.
Okay, and then follow up. So the data you're going to be collecting, is Medicare things. Are you going to collect data on Medicare supplement plans too?
Yes, sir.
You are?
Yes, sir.
Okay.
Thank you. And that went down the line of questioning that I was going to present as well, the collection of Medicare supplement plans and the costs therein that may express a concern to some of us. I'm going to go to Chairman Terry, and then we'll go to Chairman Lafferty after that.
Thank you, Chairman. And during this discussion, it kind of brought up some thoughts here that provoked some questions. My understanding is that the insurers do have information on like regional costs for if you're repairing somebody's car or home or roof or something along those lines that they can compare to. But there's nothing, say it's a car, there's no TennCare for a car, or no Medicare for a car. And oftentimes TennCare or Medicare in the health realm can pay as low as 10 cents on the dollar on some services. And so with this, you would be getting private insurance claims. We would be able to compare that potentially to what we're doing in TennCare compared to commercial insurance, at least in that region. And the issue that I try to bring up has to do with rural providers and rural procedures. And if we want to protect our hospitals in those rural areas, we have to attract providers and those that have the revenue-producing procedures in that area. And so this would allow us to kind of compare and look at that. And if we have some shared savings from TennCare 3.0, we could potentially direct that in those areas. Is that correct?
I believe so, yes.
Thank you.
Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman. I've heard the number two point something million dollars as a grant from the federal government to set this up. And then I look at the fiscal note and it's marked as not significant. Is that a one-time setup dollar that we get, the 2 point whatever million dollars? Or is that something that we are expecting from the feds year over year to keep this running? Can you just kind of square that for me a little bit?
Absolutely. It is a one-time grant of $2.5 million, so it would get the claims database established and running for the first 2 years of operation. At that point, I would have to come to the General Assembly and request an appropriation for it to continue. And talks with the vendors that I've had, they expect for a state the size of Tennessee, that would probably be around $750,000 recurring. But by that point, the database would be up and running. Hopefully, we'd be able to demonstrate the value add before we obligated any state taxpayer dollars.
Okay. And kind of, I don't know how related this is, but just a second question. I've heard about recognizing areas where we have chronic issues or outbreaks. Do we have, I know that we've got a health department there in Knox County. Do we have local health departments across the state? And if so, couldn't they provide such information as that?
Yes, sir. We do have health departments across the state, and they do provide lots of tracking of public health data. There are ways that they can provide some data, but you're not going to collect all the data because not everything is reported to a county health department. For example, I believe it was discussed in our meeting with the insurers that it wasn't until TennCare did their episodes of care that they discovered that there was a prevalence of childhood asthma in 2 particular parts of the state. And so that led them to start trying to investigate why that is. And also it's helped probably be beneficial, I'm sure they have, but when you know things like that, you can also reach out to the local providers in the area so that they can be aware that their patients might be at higher risk. And so there's a lot of possibilities in that.
Thank you, Chair. Thank you.
Thank you, Representative Mitchell. Then we'll go to Representative Hicks after their Chairman Hicks.
So let me understand this. So with CMS, right now, I can tell you what a facility, let's say it's gallbladder surgery. So I can tell you what XYZ facility in the Tri-Cities or Nashville or in rural Tennessee are accepting as payment. And I deal mostly with facilities. So I don't get down to the physician level, but if they're accepting Medicare, you can. So I can tell you what they're accepting. So in my private business, we do something called value-based pricing, so there's not a network. So if they're accepting that as payment from Medicare, then we build the self-funded plan and we offer them 140% up to 200% of Medicare as payment. The only information I'm getting, though, is from Medicare. Whoever this vendor is, this third-party vendor, they're going to have all the information. They're going to be able to have the CMS site as well as private payers sites now. So just know what you're doing in creating this and who has that information and where that information may go and how they use that information, whether you use that for good or you use that for profit. Just know what you're creating.
Chairman Hicks, you're recognized.
Thank you, Mr. Chairman. So let me make sure I'm clear. So the data that's in the database, so does it include private and public information?
It will include all the information on the claims data layout, which is going to include patient data or patient-specific data, identifying information.
Okay, so as far as the public piece, but there's no way, or the private insurance, there's no way, do they have to agree to, how does that data get into the database, I guess? How's that information imported in?
So the payers have the information in their own records, and so they would put it in rearrange the files in a data layout set, that is going to be established by the U.S. Secretary of Labor, and then they're going to submit that data to the vendor. Vendor will store that data. It will be stored in a de-identified state. The no private health information can be made public under any circumstances. But it is important that that data be collected in the first place to provide individual patient identifier numbers. That way we can track individual patients across multiple payers, multiple provider settings, and it's going to be crucial if we are trying to, say, measure the prevalence of a chronic disease in a given region. We need to be able to identify individual patients versus we may otherwise, if we're just going off of the number of treatments or something like that, we could easily over or under count.
But as far as the private payers, there's no way to force them to give that information, right, of their claims?
For a specific type of plan, that is correct. A self-funded plan governed by ERISA, would not be mandatory under this. It would be voluntary. A lot of states have a voluntary process for submitting that data. The federal bill that was passed late last December tasks the U.S. Secretary of Labor with developing a common data layout that can be used also for voluntary submissions by large self-funded employers across multiple states. So I think in the long term, we will be getting some of that data submitted voluntarily.
So those ERISA, those plans like that makes up about a third of the market. Is that close to being accurate? So there's a possibility that there's going to be, I mean, even with this, you're still talking about missing out a third of the data. So it's still, so there's, while I'm not opposed to it, there's still, I mean, there's certainly still some issues, I guess, that I can see with this, but okay, that's all I have right now. Thank you.
Well, if I may, sir, if we don't have, even if we are missing some of the data, if you use it intelligently, if you adjust for what you're missing, you can still keep that from skewing the data that you have. For example, if we are collecting all the Medicare, but we're under collecting on some of the commercial payers, we just simply need to adjust, what portion of the Medicaid we're using and what portion of the commercial payer, because it's still fundamental statistics, so you're using a sample size. The more we have, the better the data is. It's true. But if you do it intelligently, you can minimize how much it affects the outcomes of your data.
Representative Smith, you're recognized.
Thank you, Chairman. And I want to go back to something my colleague said, actually two things. Chairman Sapicki made the comment about sharing this with the federal government. And then my colleague, Mr. Mitchell, references that CMS would have access. Would you revisit again, is this going to be used for any way for a profit situation, data sharing with any sort of third parties for personal business, private business? This is all for analysis of Tennesseans' health, developing a long-range health plan and looking at things just like the episodes of care, things like that. I want to make sure that we're all clear in the record that the information you have is not going to be shared at the federal level or, for that matter, with any private entity.
That is correct. The federal government would not be able to access the database. Additionally, the vendor is stipulated in the legislation that the state will be the sole owner of the data, and that at the termination or conclusion of a vendor contract, the vendor would have to provide the data to the state in its most current form, and then provide a certificate of destruction for the data that they had. So it would, at the conclusion of the day, there would be no risk of the data being used in another way. Additionally, the legislation prohibits the data from being sold under any circumstances.
As we wind this up, Representative Mitchell.
So we're spending public dollars to create this database, correct?
Yes, sir.
So you don't think there's going to be a court case in the future for this information to be de-identified and available to someone in the public who takes this to court? Has there been a court ruling on this yet?
In the over more than a decade that they've been around, I do not believe that has happened.
Hasn't happened yet. All right, thank you.
Thank you. Any further questions or comments from Mr. Grant? Mr. Grant, I do have concerns, the amount of money that we're talking about coming in from the federal government on grants. I do have concerns. Can you once again point out to me and the committee on how we plan to invest these dollars, how we plan to continue those long-term, and more specifically, for the Finance Committee member in my brain here and the other member on the chairman of the Finance Subcommittee, tell me what the request is going to be in future years to keep this operational.
Yes, sir. So the Health Service and Development Agency is a self-sufficient agency. We get our funding from licensure fees and CON application fees. We are going to fund the 2 positions necessary to manage this database through those revenues. The federal grant will be used solely for the vendor contract. The vendor contract, as I've discussed with 3 different vendors, they have told me that $2.5 million over a 3-year period would be enough money to get one up and running and pull some reports and have access to the data. I think that the benefit to moving forward with a plan like this is that the General Assembly will, rather than having to obligate state and taxpayer dollars on something, on a vision of something, you will actually get a chance to see it up and running and see what the value of the database is before having to commit any further. And the estimates that I have received limit say that the upper end of what the state's obligation would be to continue the database would be to $750,000.
All right, thank you. Seeing no further questions or comments, thank you, Mr. Grant. We do have a couple other folks on the list. I don't know if anyone has any questions or comments for anyone else. I will not call anyone else up unless anyone on the committee has questions or comments from anyone else. Okay, we are back in session. We are back in session. Questions or comments for Representative Smith as we go forward? Representative Hicks, you are recognized.
Well, I'm going to state the obvious. I don't know if anybody else sees that, but there is a cool wind blowing, I feel like, on this particular topic. And with that, I'm going to make a motion we send this to summer study.
We have a motion for a summer study. We have a second. Any questions or comments about the motion? Seeing none, all those in favor of sending House Bill 1258 to summer study, please signify by saying aye.
Aye.
Any of those opposed, please say no. No. The ayes have it. House Bill 1258 is sent to summer study. Thank you.
Thank you, committee.
We are now on item number 6 on our calendar, House Bill 636. Representative Smith, you are recognized on House Bill 636.
Thank you, Mr. Chairman and committee. I do have a couple of amendments I need to add to that. This is House Bill 636, and there are 2 amendments on the bill.
All right. We do have a motion and a second on the legislation. We have 2 amendments. Is that accurate, Chair Lady Smith?
That is correct, sir. It's first amendment that needs to be added is 6239.
Okay. Ladies and gentlemen.
And that does make the bill, but there is an amendment on that amendment.
Okay. We have amendment tracking code 6239 being presented on the bill. Do I hear a motion? Have a motion. We have a second.
Second.
All those in favor of placing, and will be described here in a moment, all those in favor of placing tracking code amendment 6239 on the bill, please signify by saying aye.
Aye.
Any opposed, please say no. The ayes have it. Amendment number 1 is on the bill. Amendment number 2, tracking code, as the Chair Lady Smith has
It is
presented.
4247.
Thank you,
Mr.
tracking
Chairman.
code 4247. We have a motion on the amendment. Have a motion.
Second.
We have a second. All those in favor of placing tracking code 4247 amendment on the bill, please signify by saying aye.
Aye.
Any opposed, please say no. The ayes have it. We are now on House Bill 636 as amended for explanation. Representative Smith.
Thank you, Chairman and committee. Simply, this is a bill that speaks to, it issues a task of the Department of Commerce and Insurance to accept annually adequacy reports from insurance carriers to look at the provision to a policyholder or patients to make sure that there is an adequate number of providers, there's an adequate number of facilities, to make sure that patients are not waiting for an unreasonable amount of time, they're not having to drive more than 30 miles or 30 minutes. And to give you an example of what has happened, in my notebook, and I've had these for the last several months, there is a anesthesiology service in Northeast Tennessee. It received a notification from a plan sponsor that said that unless they accepted a 50% reduction in their reimbursement, that they would be moved out of the network. This particular perioperative and anesthesiology services group was the only group in the entire region that serviced all these patients, meaning that upon refusing to accept a 50% reduction in pay, that every service rendered would be considered out of network. And the purpose of having adequacy plans reviewed on an annual basis is just to make sure that patients are not being forced into an unacceptable position of paying out of network when we're fighting to keep balanced bills at bay, but also to protect the patients in a time where they have adequate access to providers, and we can monitor that as well. This gives the Department of Commerce and Insurance an opportunity to just review that on an annual basis, and this is a reporting mechanism, sir. Happy to take questions.
Thank you, and forgive me, I should have made the motion as we were amending those with those two amendments. I will make the request, and hopefully without objection from the committee, to roll those two amendments into one. Legal staff has advised me that we can and should do that, so without objection from the committee, those two amendments will be rolled into one. Thank you very much. Thank you. Any questions or comments for Representative Smith? Representative Sapicki, you're recognized.
Thank you, Mr. Chairman. So, first question I'm going to have, and you know this question is coming. Tell me about TennCare. If this is important, why can't we get the information from TennCare?
Charlie Smith, you're recognized.
Thank you, Mr. Chairman, and I'll be happy to go out of session and let TennCare testify. We accepted a friendly amendment at their request. CMS, as I understand, and I'll be happy to stand corrected, CMS has to govern all TennCare waiver and or TennCare programs separately. And should this be under the jurisdiction of the Department of Commerce and Insurance, it would instantly be out of compliance at the federal level. And to avoid a standing that would be inappropriate within CMS, certainly we don't want to do that to our TennCare Bureau. However, there's nothing that prevents this committee nor the Department of Health for seeking a adequacy report separate from the TennCare Bureau that would model such a report that would be available for all these paying plans. So I think that upon this becoming law and us being able to see the utility to make sure that patients do have access to mental health services, to substance abuse services, to make sure that, you know, all of these services are available, I think it would serve as a tremendous model for TennCare to come forward with a similar access plan to report to this body on a regular basis.
Let me go to Chairman Lafferty first before we go into recess. Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman. Sponsor, I just wanted to make sure I heard you right. This is strictly a reporting bill. This is not compelling any agencies, any departments, any insurance carriers, anybody to do anything other.
Chairman Smith.
Within the bill, it empowers the Department of Commerce and Insurance to accept these access plans and to monitor to make sure that plans are indeed adequate. It does not stipulate within the bill specifics of that definition. It looks at the number of providers that would be necessary to take care of a population according to a plan, the distance and demographics. However, it leaves it up to the department to make those determinations, but it just receives the access plans that are submitted on an annual basis, and it directs the department to ensure that patients do have access to an adequate network.
Follow up, Chairman Lafferty.
So the department deems not adequate. What happens then?
Chairlady Smith.
Already in code, there is a fine that's available. This assigns that to be $500.
Holy cow.
Thank you. Any questions or comment? I think a request has been made to go into recess to hear from TennCare. Without objection, we will go into recess. Ms. Reed, you know the routine. If you could tell us who you are and who you're with and address the issue, and then we'll ask you questions if needed. So you recognized Ms. Reed.
Sure. So to address Chairman Sapicki's question, Chairman Smith is correct that there is a federal regulation which requires TennCare to be the single state agency, and we are unable to delegate the network setting standards authority to anyone other than ourselves. We do currently follow what's called the community standards protocol set forth by CMS, and we are currently meeting all of those network adequacy standards.
Chairman Sapicki.
So to clarify, if, and this is a very complex bill, so you got to work through with this with me, please. So you guys manage your adequacy yourselves right now, correct?
Yes, we follow that community standard protocol set forth by CMS.
Okay. You do have a lot of data that you manage yourself, correct?
Sure.
If we allowed you to stay in control like you are and required you to also give that information to the proposal of this bill, could TennCare do that?
I think, yeah, anytime anyone wants to see what the network looks like in a particular community or county for any type of provider type or specialty, we would be able to provide that information to you.
Would the network adequacy that TennCare uses, would it be equivalent to what we're discussing here?
So the current standards are, it's a 30-mile, 30-minute radius for PCPs. And then it has to be, for specialty, 75% of members within a 60-minute, 60-mile radius. And then all members have to have access within a 90-mile, 90-minute radius. We also do provide transportation.
For those not knowing PCP, what's PCP?
Primary care physician.
Thank you very much. And do you have the authority to fine providers?
We do.
And how much do you fine them?
Well, we let our managed care organizations go out and recruit and contract with physicians. So our MCOs do that for us, which is allowed under that community standard.
Could you and would you give that data and information to this bill so we can have data across the whole state of Tennessee? Because you have 1.4, 1.6 million people in your database, correct? Ish?
About, yeah, 1.5 million
1.5
enrollees.
million,
Yeah.
so that's pretty close.
Yeah.
That's a big hole in our data on network adequacy, because is there an overlap between the two? Would there be an overlap between the two if we don't share the data?
Sorry, I
Would
might
there-
not
Let me ask
understand.
a better question then, I'm sorry. Would there be holes in this bill if you did not share the data?
I'm not sure. I do think if there's a question or if any member wants to receive what our networks look like, then we can produce that.
Okay. Okay.
Any further questions or comments for TennCare? Seeing none, thank you very much, Ms. Reed. Without objection, we will go back into session. All right. Questions or comments for Chairlady Smith on the legislation? Chairlady Smith, you're recognized.
If I might want to take the opportunity to address Chairman Sapicki in his line of questioning there about the holes in the information. You know, one of the things I want to make sure that there's no part of this bill that's tied to the All Payers Claims Database. This is a standalone reporting mechanism where the Department of Commerce and Insurance would receive adequacy plans on an annual basis through determination and review about primary care access, specialty access, as well as any intermediaries. There would not be any data submitted and housed because I think we're confusing the two bills. I want to make sure that there's no confusing the all payers claims database. So there's not any information that's shared other than just a generic access plan to overview the patient policyholders and their access to care. Thank you, Mr. Chairman.
Thank you. Chairman Subcommittee, you're recognized.
And I do appreciate that, and the chairman knows I've had some issues with this bill. To me, it appears the possibility of heavy-handedness here on providers. Personally, I need more information on this bill. I would like to make a motion to send us to summer study.
All right, thank you. We do have a motion.
I do object.
Okay. All right, I've heard a motion for summer study. Do we have a second to that motion? All right. I don't know if you have anything to object to. I'm sorry. Could you, Chairman Kumar, you're recognized. Okay.
I withdraw my motion.
Okay. All right, ladies and gentlemen, any questions or comments for the Chair Lady Smith on the legislation? All right, are you ready to vote? All those in favor of sending House Bill 636 to full committee, please signify by saying aye.
Aye.
Any those opposed, please say no. No. The ayes have it. It moves forward.
Thank you, Chairman and Committee.
All right, forgive me as I turn my page here. I feel like my head's on a swivel up here quite often, and I know I'm going back and forth like a tennis match as this is going on, trying to make sure I hear and see everyone. So thank you all very much for your patience. We are now on item number 7 on our calendars. Item number 7 is House Bill 2. Chair Lady Smith, you're recognized on House Bill 2.
Thank you, Mr. Chairman and Committee. There is a drafting code, an amendment traveling 6541 to the
We do
bill.
need a motion and a second on the legislation. Is that present? We have a motion. We have a second on the legislation. We are looking at amendatory language.
6541 is the drafting code, sir.
Alrighty. All right, tracking code 6541 is amendment number 1 to House Bill 2. We'll go ahead and entertain a motion on that. Motion? We have a second. All those in favor of placing amendment tracking code 6541 on the bill, please signify by saying aye.
Aye.
Any of those opposed, please say no. The ayes have it. We are on your bill as amended. Chair Lady Smith.
Thank you, Chairman. This is essentially codifying the federal law, Public Chapter L 116-260, which is U.S. Code 9816. In December, I've referenced this already. In December 2020, the Federal Surprise Billing Act went into law, and this simply puts into Tennessee code that despite the fact that that law was written to cover the ERISA plans, the Employee Retirement Investment Securities Act plans, that our Department of Commerce and Insurance will enforce that law on all plans and give individuals an opportunity for remediation. This particular amendment, Mr. Chairman, has 2 other provisions that I want to bring the committee's attention to. Should this pass out of this committee, those 2 provisions will be stricken, and this will be solely a bill that codifies the U.S. code into state law to make sure that we have all of our lives covered through surprise billing fixes. And with that, I'll be happy to take specific questions, Mr. Chairman.
Thank you for that explanation. Questions or comments for the sponsor of the legislation? Chairman Kumar, you're recognized.
Thank you. It has been a very complex situation. I admire the chair lady for having worked a lot on it. There are questions about how the federal law preempts or what it does, and I believe the department wanted to testify on this matter. I think we should hear them.
Thank you, Chairman Kumar, and here I go, turning pages again. I will get to where I need to be. All right, the request has been to go out of session. Chairman Kumar, I'm looking at the list for a department to speak on this. I do not have one of our state departments, forgive me, we do have a Department of Commerce and Insurance. Is that your request, Chairman Kumar?
Yes, Mr. Chairman.
Yes. Representatives from the Department of Commerce and Insurance, if you would please come forward. Seeing no objection into going into recess, we are now in recess. Gentlemen, if you could please introduce yourself, tell us who you are and who you're with, and begin your testimony.
Thank you, Mr. Chairman, Committee. I'm Alex Lewis with the Department of Commerce and Insurance. Also with me is Patrick Merkel. He's the Director of Insurance at the department in our Division of Insurance. So I'll let Patrick give some opening remarks, and then we'll be available for questions.
Mr. Merkel, tell us who you are and who you're with.
Absolutely. Patrick Merkel, I'm the Director of Insurance for the Department of Commerce and Insurance. And in recent prior life was the Chief Counsel for Insurance as well. I'm going to disagree with Chair Lady Smith about the application of the federal law. I've done quite a bit of studying and listened to a number of calls with the NAIC, insurance commissioners and staff across the country, as well as CMS, and it's the department's feeling that the federal law will cover those plans that are regulated by the department, the individual plans sold on and off marketplace, as well as the small group plans that we regulate. So I believe that was Chairman Kumar's question, and I'm happy to, if I've missed or left anything out, I'm happy to help with this.
Thank you. Chairman Kumar, you're recognized.
Thank you, Mr. Chairman. Thank you. I mean, it's a very clear and straightforward statement. So since federal law will cover or preempt anything that we pass, and so I guess this is not a question for you, why are we doing this? That's really not for you because you're not doing this. Are you concerned that when the rules are put out, I believe later part of this year, we don't know what those rules would be, but what is your feeling about it? Do you think overall the general philosophy or the intent of the Congress will apply?
That's correct. And I actually would like to clarify one particular thing that you said. You used the word preempt. The federal law does specifically say that states can adopt their own surprise billing provisions. Okay. So that the states, I think there are about 18 or so that had them before December. Those are not stricken. They're continue to allow to be able to run their programs, and states can pass their additional programs. I think you're correct with the statement that there is a lot of things that are unclear, and that there's going to be a lot more clarity as the year progresses, and the Department of Human Services, the Department of Labor, surprisingly, the Department of Transportation, and I think there's probably 2 other federal agencies that are involved, all kind of work to sort of give a little bit more framework to the provisions that were passed, and we just don't know yet about exactly the extent of whether there will be preemption, and they'll consider preemption, and what they may determine to be mandatory, what they may be may determine to be discretionary in the state's judgment.
Chairman, if I can add into that, Alex Lewis again, I think to clarify the department's position, the Federal Act amended 3 sections of federal law: the tax code, ERISA, as the representative, the sponsor mentioned, but also the PHSA, the Public Health Services Act. And that is the provision that makes the federal act applicable to those traditionally thought of as state-regulated plans. So it's not that the department will make some determination that we will apply this to state plans. It's that Congress, in passing the law, applied it to those state plans. And so, Chairman Kumar, I think to the heart of your question, the department feels that we do not need to adopt a law in order to protect Tennesseans at this time. And so under the federal act, they will be provided protections from a surprise medical bill under the federal law.
Well, thank you. I was going to say, well, we live in uncertain times, but I think you brought clarity, and we appreciate it. Thank you. Thank you, Mr. Chairman.
Thank you. Question, Chair Lady Smith, you're recognized.
One question, in my office, when we were talking about this amendment, I asked the simple question: if there are providers or hospitals that are faced with a surprise billing construct and they're not an ERISA plan, and they choose to go to court and sue to avoid the construct of IDR as applied by this law, if this is not in our Tennessee code, and yet those plans are governed by the Department of Commerce and Insurance, unless I misunderstood you, you could not give me a firm answer that there would not be a remedy, that patients would still be at risk in those situations because of potential lawsuits. Thank you, Mr. Chairman.
My recollection of that conversation was that you referenced lawsuits. We do not believe that patients will be have exposure to a surprise medical bill for those state-regulated plans. So for a non-ERISA plan, patients will be protected from a surprise medical bill, because the federal law applies both to those state plans, but then also applies to providers in general.
Charlie Smith, you're recognized.
And equally, I know we're focusing on patients, but also physicians, and providers, their reimbursement. If you would speak to that, so there is no room for anyone to sue to escape the federal law.
So there's an idea that with enough amount of money and a lawyer that's willing to file the suit, anybody can sue anybody. I think that you will probably see some lawsuits. I don't think that they will be fruitful, and I think that the providers will get paid under this, and there will be that the carriers are going to follow the IDR process, and we're going to go forward on that way. And I think that if there are carriers that are not doing this, we're going to be having conversations with them and under our statutes and saying you need to be following the law, or else there will be ramifications.
And additionally, we can't speak to the provider payer contract, network contracts. There may be provisions that prohibit lawsuits, as you mentioned, in those that we don't see.
Thank you. Any further questions, comments for Department of Commerce and Insurance? Seeing none, do we want to hear from anyone else while we are in recess? Okay. Chair Lady Smith, you're recognized.
If the Tennessee Medical Association, if they're on the list to testify, I'd love to hear their. If not, that's not a problem, sir.
We do have Julie Griffin with the Tennessee Medical Association on our list to testify. Entertaining Representative Smith's request. Ms. Griffin, if you could tell us who you are and who you're with, and tell us what you want to hear.
Julie Griffin, Tennessee Medical Association. Chairman, members of the committee, I appreciate you all giving me the opportunity to speak today. This issue has been around this General Assembly for at least 8 years now. It took the federal government in December a lot of long meetings and a lot of negotiations to get the federal bill to where it is. I made a commitment to this General Assembly several years ago that I was going to find a way for you all to make sure your patients in your districts were protected. That was my commitment. It would be whatever we brought would be fair to both the payers and the providers, and I feel like we did that. What I am very concerned with, and it would be easy for the Tennessee Medical Association to sit here today and say, okay, let's just let the federal bill go. And then if there is a lawsuit, have people fall through the cracks. I don't want that to happen to your constituents. I don't want there to be a lawsuit because I do think that there was enough ambiguity in the federal law that could lead providers, and particularly providers, in a posture that in the state-regulated market, they could file lawsuits, potentially get injunctions to hold off the federal law, and then lo and behold, 20 to 30% of the markets that are in your communities, patients fall through the cracks. I don't want to see that happen. It has obviously been a big issue. We had what was 23-page bill that we filed that was pretty similar layout to the federal law. There were some exceptions. Dr. Kumar and I have spoken about some of his concerns in the original bill. So we tried to cut this down to make it really, really clear that just to make sure that there was no question that Tennessee was going to follow the federal law as it related to the to the state-regulated insurance market. I will leave it up to you if you all want to take it to chance, but I didn't want to do that, and I made you all commitment, and that's why this bill's in front of you in the posture that it is today. There are 2 provisions that I know Representative Smith has agreed to take out for the full committee. One that pertained to an all claims database, because there is a lot of questions as to where the information about a median contracted rate is going to come from. Right now, in the federal law, it doesn't tell you where the median contracted rate is going to come from, and the only person that has that information is the insurance company itself. I'm not sure that my providers are going to just take it on the chin that the insurance company is going to give them the actual rate. That's why there are things like all claims databases that were put into the federal law to be created so that you all would have independent, verifiable data for your arbitrators to look at. That's going to come out in the full committee as I understand it. But again, if you all don't want to move forward, I understand that, but I do think that you could potentially be putting some of your patients at risk. I respectfully disagree with the department. I think there are patients that could fall through the cracks, and I think that this bill, as amended, will ensure that that doesn't happen.
Thank you. Questions or comments? I will pose a question. The amendment we adopted on the piece of legislation, it's essentially a watered-down amendment from where we started with the several-page amendment.
Absolutely.
And the request will be that we will water that down even further with a potential amendment in full committee.
Correct.
Why are we doing that? Why are we basically codifying that we're going to follow federal law?
Why are we codifying that we're going to follow federal law?
Yes.
Because the federal law, and again, attorneys can disagree all day. We all know that an attorney can argue any side of a subject. I have attorneys at the AMA that believe the federal law does apply to the state regulated market, but I also have attorneys at the state and the federal law within the AMA who believe that it was not explicitly clear that the federal government took away the right for a state regulated market to be regulated by the Tennessee General Assembly in order to push their own regulations. It's muddy and muddy at best. And I think that most anyone you ask would tell you it's muddy at best. I'm going to point out Congressman Rowe, former Congressman Rowe, was a key member of the negotiating group that negotiated the federal bill, and he has told me that the state probably needs to put in their own language to ensure that the state regulated market, it applies to the state regulated market, because there is so much clarity, there's so much clarity that needs to be done with the federal law. And again, the rulemaking, yes, I do believe that we might get some clarity with the rulemaking, but even that can be negotiated and fought. So we just wanted to make sure, again, we, the Tennessee Medical Association, wanted to make sure that we provided an assurance to the members of the General Assembly that when you all go home after the federal law is implemented in 2022, that none of your patients would be falling through the cracks. And that's what we are attempting to do.
Any further questions or comments? Chairman Subicki.
So I'm kind of confused here. We have the amendment, and we have the amendment, and I understand that that one section is going to be all that remains that codifies the federal law. It's going to come down anyway, correct? The federal law is going to be implemented in Tennessee, correct?
For sure for the risk plans, and I have every belief that the Department of Commerce and Insurance plans to regulate the state regulated market that same way. But as to Representative Smith's question about potential lawsuits, I would hate to find ourselves in a position where those patients fell through the cracks while we waited on a lawsuit that could take 8, 10, 12 years to play itself out in the courts as to whether or not it applied to the state market. And that was why we believed that it was important to, at the very minimum, codify that this was the way the state of Tennessee was going to do its balance billing laws for the state regulated market.
Chairman Subicki, as we finish up.
So could we not allow the federal law to be implemented with all the rules and the procedures and then know what to fix? Because right now we're trying to, if I understand right, we're trying to fix something that we don't know how to fix because it hasn't been implemented yet. So why would we, I'm just struggling here, why would we try to fix something that we can next year? We can come back and fix it next year if we have to, based off of what we see. Are we just kind of?
I absolutely understand that question. And I don't know that I disagree with you, but I also know that I don't know what the problem with making it clear that you all want to make sure everybody is covered when that law begins in 2022 or 22. The federal law will go into place in 2022. You all won't even come back here until January. You're not going to know if anybody is going to be falling through the cracks until it's had time to work. I'm just trying to make sure you all don't go home to your constituents and have a constituent say, I thought you all solved my problem. I don't want that to happen to you. That was my commitment that I made to all of you all years ago when we started bringing this legislation.
Chairlady Smith, you're recognized.
And I just want to thank everyone involved, because this is one of those bills where I know TMA has worked on this since at least 2014. I've been in the rooms with this. And what I'm hearing everyone say is we all agree that we want the federal law to work. And I think that we're all a little surprised that there is such resistance to putting a small statement in Tennessee code that the Tennessee Department of Commerce and Insurance will apply and enforce this law with no other parameters. But at the will of this committee, I'm listening to do whatever. I do think that there is no harm, there's no cost to put this into code, but I will listen to the committee and at the advocates of our Tennessee providers and patients. But in the meantime, again, we're not trying to fix something. We're trying to make sure that there aren't patients that fall through the cracks as the fix is applied. Thank you, Mr. Chairman.
Thank you. Any further questions, comments while we're in recess? We'll go back into session. Chairman Kumar, you're recognized.
Thank you, Mr. Chairman. I share the feeling of the committee and Chairman Spickey that it is confusing. Considering that we are concerned about a lawsuit for the federal law, Tennessee law is not any more immune to a lawsuit. Tennessee law can be sued too. And we think that federal law is so open with holes that there can be lawsuits. Then if it is that bad or law full of holes, why do we want to codify into our Tennessee law? We're importing the same problems by taking the same law. Considering that any law we pass is also equally open to lawsuit, considering that we think federal law is open to lawsuits, why do we want to adopt it? I'm trying to figure out why we are doing this. The lack of clarification because the rules are not available yet is equally concerning, and I don't know why we need to act on it. I know, Chairlady Smith, you have worked very hard on it. You have put a number of amendments trying to adjust things, and I admire you for that. But I sincerely would request that please consider rolling it to next year or studying it through the summer so that we have the federal rules available and then fix what we think needs to be fixed. We need clarity before proceeding. We need a diagnosis before treating this patient. Thank you, Mr. Chairman.
Thank you. Chairlady Smith, you're recognized.
And we're back in session, is that right, sir?
We are.
I will make a motion to put this on the first calendar of the insurance company and insurance calendar in 2022. And I would ask that Sabi Kumar be the primary co-sponsor on the bill, and we will work toward resolution. Thank you, Mr. Chairman. May I have a second on that motion? That motion? Thank you.
We have a parliamentary concern. The number of calendars that this bill has been on has produced a concern. Absent passage, we're not quite sure if we can take that initiative on this piece of legislation. So we're going to have just a quick reference there. Chairlady Smith, while we're discussing.
Mr. Chairman, I'll be happy at the request of the committee. If we pass it into full committee, it will be the immediate motion, the immediate motion of this sponsor to put it on the calendar for 2022.
Okay, let me see what our posture is for a second. All right. Thank you very much, and got some wonderful rules that we are working through, and they're somewhat different for us. So as we work our way through this is the first year under these the roles and the times we're allowed to have some roles. Absent passage of this legislation, the motion that we heard cannot be accepted. So that is the posture in which we are. Chairman Kumar, Chairman Lafferty, you're recognized. Forgive me. You had raised your hand earlier. Forgive me.
Always, Mr. Chairman. Thank you. I haven't faced this situation from the top down. I have had a couple of instances with our colleagues in other committees where we have taken policies and tried to codify those. I have opposed that because I kind of feel we're doing the same thing this time from the top down. I just wanted the sponsor to know that I would probably be a no vote in this committee and probably in the following committee. So, thank you.
Thank you. Chairman Kumar, you want to be recognized again?
Thank you, Mr. Chairman. And I'm sure the sponsor understands with all this confusion and things going on, it's really a matter of semantics, whether we say put it on next year's calendar or summer study. With that understanding, I think what fits in the picture at this time is that I will make a motion for summer study.
Okay. We have a motion and a second to send House Bill 2 to summer study. Any questions or comments on the motion? All right, all those in favor of sending House Bill 2 to summer study, please signify by saying aye. Aye. Any of those opposed, please say no. No. The ayes have it. Yeah. Chairman, here's no's. Here's ayes. The bill will be placed in summer study. So thank you very much. Ladies and gentlemen, thank you for your diligent hard work and attention. This has been a tough committee. This has been a tough day for many of us. And most folks watching don't know it's been a tough day for many of us. So I want to thank you for your indulgence. Thank you for the time that you spent today. Entertain a motion that we will adjourn. We are adjourned.